Okay, so yeah, I think we have some kind of noise in the YouTube. We will try to fix it, but we will also I will ask you to record this presentation. I will record the presentation via Google Meet, so we can also share with you later if you want. So we are almost welcome Professor Daryl Jones. Daryl is an intensive care specialist at Austin Health in Australia, and also a professor at Monash University and at the University of Melbourne, and has previously been an advisor of the Australian Commission on Safety and Quality in Healthcare. He has a large experience in rapid response system, and you make this presentation for us. Thank you very much, Daryl.
Thank you, Paulo, Professor Paulo. Excuse me if my cat comes into the screen. I'm just going to present an overview of the history of rapid response systems in Australia, and just to acknowledge our Brazilian connection with Dr. Larissa and Dr. Bruno, who have both come pretty often to learn about rapid response systems, and we've been doing some collaboration together. I have no conflicts of interest other than the advisor role. I don't get paid for those, and I'm also on 3 grants looking at sepsis and referring patients, and I don't derive any income from those. Today I'm going to talk about the history of rapid response systems in Australia, and basically I'm going to divide it into 4 parts. Before the rapid response system, and then the early phases up to 2010, and then a very important milestone in Australian healthcare when some national standards came out in 2010, and then I'm going to describe the features of a mature rapid response system and some evidence and just to paint a picture of how common rapid response team reviews are in the context of ICU admissions. So before 1995, there was a lot of clinical deterioration in hospitals, as Professor Paulo just alluded to. So this is a landmark study. It's published in the Medical Journal of Australia in 1995, and the researchers looked at 14,000 admissions across 6 states in Australia in 28 hospitals, and they found that 16% had an adverse event that was caused by the healthcare management. A half was deemed to be preventable, and roughly 14% had permanent disability, and 4.9% were associated with death of the patient. So this was really a landmark paper. It made the press and the news and the newspapers in the country at the time, and really people were looking for strategies to address this systematic problem. Another study, and there are several from overseas, one done by Michael Besen, showed that these adverse events were preceded by signs of instability in a large proportion of cases, and this included changes in the patient's status, as documented in the patient's notes, a need to increase oxygen, and most importantly, derangement in the patient's vital signs. These were present for some time. It wasn't sudden and unexpected, and the junior doctors and nurses did not have the skills to identify and reliably treat these problems. So this is one of my favourite slides. So Michael Besen termed this in clinical futile cycles, where nurses and junior doctors repeatedly review the patient and try to institute treatment, and maybe a senior doctor or a subspecialist will come and review the patient, but this all takes a long time, and all the while patients are deteriorating. So the early phases of this adaptation in Australia were basically a medical emergency team, and I choose that term deliberately, so it was a doctor-led rapid response team. And essentially we had very simple calling criteria, and the patient only had to breach one of these criteria, and the nurse
and to a less extent the doctors on the ward would call for help. and then the staff would come and calmly and casually come and talk about the patient. This is a photo of an actual Met call from about 2015, I think, something like that. And you can see that the staff have cards to allocate their role. We call it role allocation. And the team would come and assemble before the patient had severe deterioration. There are several very important people in the development of this process. Ken Hillman really was the pioneer, but Michael Buist, that I've just alluded to, was an important person. And at the Austin Hospital, Ronaldo Bellomo, who you may or may not know has recently passed away, and a nurse named Donna Goldsmith were really instrumental in developing, refining, and evolving this model of care. So the first description of a medical emergency team was in 1995, exact same year that that paper was published, but really was a simple description of the role of the team and the type of things they did and the patients they reviewed. The first evidence for the medical emergency team actually came from Michael Buist's team. That's from the same state as I'm in Victoria. And they showed that, I don't know if you can see my pointer, that with increasing numbers of medical emergency team calls, there was a reduction in cardiac arrests, but also a reduction in hospital deaths as well. I don't know if you can notice, but the Met calls started here and the cardiac arrests were already perhaps starting to reduce prior to that. So this is one of the criticisms of the Met, is that this is an association and it's often difficult to prove causation. At the Austin in the early days, Ronaldo and Donna showed major benefits after major surgery. There was a reduction in adverse events, ICU readmissions, and a 37% relative risk reduction in mortality for high-risk surgical patients. There were also reduced cardiac arrests, and this is a landmark paper in the Medical Journal of Australia. So this shows before the Met, and you can see we had 15 to sometimes 20 arrests every month. And in the year after the Met started, there was a marked reduction of almost 2/3. I started doing research on the Met in about 2005 and followed on from Ronaldo's study, the initial study looking at major surgery. And we demonstrated that the benefits in survival were not just immediate, they were actually sustained out to a 1,500-day period. And even after adjusting for confounders, this mortality benefit persisted. What was happening in the rest of Australia at this time? So this graph shows the number of hospitals that report having a Met, and this is the time scale from 1995 to 2005. And we've listed all the publications down the bottom. And you can see that by 2002, 3/4 of these 80 hospitals had implemented a medical emergency team. So these are METs, these are not nurse-led rapid response teams. The only study that had shown in Australia a benefit wasn't published until 2002. And you can see all of these studies, these international studies, looking at adverse events. So in Australia, the medical emergency team was implemented in response to studies reporting adverse events. They weren't implemented in response to any evidence. The next major step in the rapid response system in Australia came in 2010, where we introduced national standards. And this is really a very pivotal paper. I would strongly recommend you have a look at it. It's only about 30 pages and it's very easy to read. That was introduced in 2010. And 2012, we had healthcare standards introduced, and there were 9 of these initially. The purple one is deteriorating patients that this is based on. And these became mandatory in January 2013, and hospitals are now accredited on the basis of these standards. So there's a set of stipulations and the hospitals need to comply with them. So these principles are very, very simple. The first document outlined 8 principles, and they basically outline things like the measurement and documentation of vital signs, steps to escalate care, the mandatory requirement for a rapid response system, how doctors and nurses and other people should communicate and hand over, And then the organisational supports, such as governance and education, the need for audit, quality improvement and feedback, and then technological solutions. One of the pivotal steps in this was the introduction of very clearly laid out observation charts. These are actually called observation and response charts. You can see respiratory rate is right up the top, and it goes through the various vital signs. These are graphed, they're not written down in numbers with time, and you can see that they're color coded. So the purple means that you must call a medical emergency team call, and the orange is a pre-met, which I'll allude to in a minute. So this provides decision support for the staff at the bedside to document the vital signs, observe trends, but then also to trigger a medical emergency team or a pre-met. In 2025, moving forward to where we are now, the vast majority of Australian hospitals, particularly those within intensive care, have a fully staffed rapid response team, and a large proportion even have a consultant or a specialist providing oversight of that service, particularly during weekdays and work hours. Our vital signs are typically charted on the electronic healthcare record, so we don't use paper-based charts now. And we typically have 3 tiers of a response. So we have a Respond Blue for cardiac arrests and immediate life-threatening emergencies, a rapid response team, which is typically ICU-based, but not always. It's the vast majority though. But importantly, we now have a pre-rapid response team call, and that's for milder levels of deterioration, and the usual treating team respond to that. At the Austin, that's called an urgent clinical review. We have a deteriorating patient committee, so we don't have a resuscitation committee anymore. We have a deteriorating patient committee that oversees the elements of the national standard, and we have training for hospital staff at multiple different levels, and very, very comprehensive data collected in our electronic healthcare systems, so we can monitor every month to see how we're doing compared to ourselves and in some respects to other hospitals. And how does this work? Well, this is data from the Austin. These are publications. In 1999, this was 2 years after I started at the Austin, there were 8.3 cardiac arrests a month. And this is just on the general ward, not in the coronary care unit or the ED. So that was 4.1 per thousand. And the last time we published a paper on it was January 2022. And we had a staggering 10 in 12 months on the wards. So that's a more than 90% reduction in cardiac arrests at the Austin over a 23-year period. But this has been proven to be effective across the whole of Australia. And I'll just walk you through 3 studies. The first one was for the whole state of Victoria, looking at 4.7 million hospital admissions over a 7-year period. Over this period, there were fewer cardiac arrests in the hospital wards, fewer heart failure episodes whilst the patient was in hospital, and less arrhythmias. And these graphs are divided into before the national standard, during the implementation of the national standard, and then after the national standard became mandatory. So you can see that cardiac arrests declined quite dramatically, as did heart failure episodes, and arrhythmias were increasing, and they seem to have plateaued out. So in New South Wales, one of the other major states, over a 6-year period, looking at 7 million hospital admissions and 5,000 cardiac arrests over 35 sites, there's been a similar reduction from 1 per thousand down to about 0.56 per thousand. And then finally, across 110 intensive care units between 2008 and 2014, these are patients that were admitted to an intensive care after a cardiac arrest. And you can see again that before the national standard was introduced, the rates were relatively constant, and then there was a dramatic reduction which was sustained after the implementation of the national standard. Moreover, the patients were less sick, so their baseline Apache score went from 100 down to 95. They were less likely to receive ventilation in the first 24 hours, from 71 to 63%. Their ICU mortality went from 47 to 42%, and their hospital mortality went from 57 to 50%. How common are cardiac arrests in hospitals now? This is old data now. It's almost coming up to 7 years old, but this was from 7 hospitals over 1 year, all of whom had a very well-developed rapid response system. You can see that a very large number of hospital admissions over this time period, 15,000 rapid response team calls, and the number of cardiac arrests per month, you can see, was only on average 2 per month. And when you look at the rate of cardiac arrests, it's about 0.6 per 1,000 multi-hospital day admissions. So relatively infrequent. What about patients who are admitted from the ward? So this is a 1-year study looking at 12.6 million hospital admissions and about 250,000 rapid response team calls. About 1 in 12 patients after a rapid response team get admitted to ICU. But more importantly, of the 27,000 ICU admissions that occurred over the ward, from the ward over that time period, almost 3/4 occurred in the context of a rapid response team review. So really now this is becoming the major mechanism by which patients get into the intensive care after they're seen by the ICU out on the ward. So in conclusion, rapid response teams were introduced relatively early, before May 2002 in Australian hospitals, but they were introduced in response to studies reporting on adverse events rather than any study that reported a benefit. The early benefits were mostly on cardiac arrests and to a lesser extent post-op surgical morbidity and mortality. National standards are now in Australia for every hospital in Australia, and they've been mandatory since 2013. And since they've been introduced, there's been further improvements in outcome, not just cardiac arrest, but other important causes of morbidity. And most hospitals have a staffed rapid response team, so they have dedicated staff, and rapid response teams are a common pathway to be admitted to intensive care. Cardiac arrests are now very, very uncommon. So we see on average about 1 or 2 per month on the general wards in most big hospitals. And that's it. Thank you very much for your attention.
We thank you very much, Professor Daryl, for sharing all of this experience with us, and we really can see that the rapid response systems make difference in the safety and the outcomes of the patients. We will have time to discuss after all the presentations, so if you have any questions, please type on the chat and we will respond at the end. I think we had a small problem in the beginning with the software of the transmission from the meeting for the YouTube, but I think we sorted it out at time for you to listen to this brilliant presentation. So we are moving for our second presentation. I invite Dr. Larissa Bianchini from University of São Paulo. Larissa is an intensive care physician, specialist in internal medicine and intensive care in University of São Paulo. She works as intensivist in Hospital das Clínicas, University of São Paulo, and in Hospital of São Luís, Itaim Vila Nova Star, and she's a PhD student in the University of São Paulo and a fellowship in clinical research in Hospital of Heart, HCOT, São Paulo. Thank you very much, Larissa. And
thank you, thank you, Paulo, for the introduction. It's really nice to be part of this meeting. And today I'll briefly talk about the evidence on rapid response teams in low and middle income countries. So as Professor Daryl brilliantly presented, we currently have a solid evidence that rapid response teams and systems associate with decreased interhospital cardiac arrests and mortality outside the ICU. There are several meta-analyses on this issue. It stands out, though, that when we evaluate the studies included in these published systematic reviews, over 90% of the countries included are high-income countries from Europe, North America, and Oceania, especially Australia and USA, which is interesting because looking to ICU demographic data, the average of ICU beds per population is 3 to 10 times higher in high-income countries than low and middle-income countries, even though the burden of critical illness is higher in low and middle-income settings, because we do have a larger share of global population, higher burden of sepsis, less resourced healthcare systems, and higher inequality in critical care delivery services. And these challenges, they start at the bedside, but they extend to government and research initiatives as well. Therefore, rapid response teams seems to make even more sense in such resource-constrained scenario. To further explore this issue, we conducted a scoping review, aiming to map what is the published literature about rapid response teams in low and middle-income countries. We used the World Bank Atlas for our income classification and included only original studies that were published either as a full text or a conference paper. Conference papers were also included to account for the no underrepresentativeness of low and middle-income countries in peer-reviewed journals. So our initial search in 3 databases retrieved nearly 7,000 records, of which 5,683 were screened for title and abstract, and 184 were assessed for full text eligibility. We finally included 52 studies in the review, of which 36 were original papers and 16 conference abstracts. As this map shows, most of the studies were from Brazil, followed by India, and there were really few reports from countries in the African continent. The first reports were 2 conference abstracts published in 2007, and there was an increase in the number of publications in the last 10 years, especially after 2014. The most frequent study design was before and after study, followed by cohorts. 50% of the hospitals were public, and in 2 of the reports, there was a description of a specific critical care outreach team. 50% of the studies reported hospital mortality, 40% code blue incidence, and ICU admission. 34 studies had data about team composition. The most frequent participant was somebody from the medical staff, usually an ICU fellow or an ICU physician. In 16 studies, a nurse also participated, and in 7 of the studies, a physical or respiratory therapist as well. We were not able to perform a quantitative synthesis of the result because most studies did not report ART dose or mortality in a standardized way. But when we look to the 4 before and after studies that were published as a full text, we do see a reduction in the incidence of code blue after team implementation, and in some of the studies, a decrease in mortality as well. To summarize our findings, there was, as we saw, a time lag in publications in low and middle income countries compared to high income countries of more than 10 years. Most evidence for RRT came from observational and before and after studies that evaluated the primary role of RRT in managing clinical deterioration. Most teams included nurses and physicians, and even though reported outcomes were heterogeneous, they usually included some metric about cardiac arrests, absolute or relative numbers, and hospital mortality as well. With that background, I would also like to share our own institutional initiative, which was the ICU Without Borders project that was conducted initially in 2024 in Hospital das Clínicas. of São Paulo, which is one of the largest public hospitals in Latin America. It was led by my colleagues Bruno, Gabriel, and Luis, and it consisted of an ICU specialist and an ICU fellow that evaluated all patients for whom an ICU bed was requested during Monday to Friday. We do have a rapid response team that attends mostly to code blue calls, but one of our major challenges is a large number of critically ill patients and the frequent delays in ICU admission because of overcrowding. So the aim of this project was to provide early critical care expertise and support for patients in the wards until ICU admission, to help to identify and prioritize patients that were most likely to benefit from intensive care in a scenario of scarcity of beds, to support goals of care discussion, and try to avoid potentially inappropriate ICU admissions. So 566 patients were evaluated with a median age of 59. Half were female, with a median Charlson comorbidity index of 3 and SOFA of 4. Patients were originated both from the wards and the emergency department, and the most frequent reason for ICU request was altered level of consciousness. 30% of the patients were using vasopressors at the time of the request, and a quarter of them were mechanically ventilated. The most frequent priorities were 1 and 3, defined by the automatic system classification using the Society of Critical Care Medicine priorities. But as we can see in this figure, after the evaluation by the ICU team, there was a reclassification in some patients with an increase in the ones considered priority 2 and 4, which are the ones judged to have a lower probability of survival. In 40% of the times, the team performed a direct intervention, frequently a prescription adjustment. The median time from ICU requests to ICU admissions was 27 hours, and the care plan considered most appropriate after evaluation was usually unrestricted ICU admission. Finally, 50% of the patients actually were admitted to the ICU, and 40% of the patients experienced clinical improvement with no further need for ICU admission. So summing up what we have learned so far, I would like to highlight that rapid response teams and critical care outreach teams are feasible in low and middle income countries, even though current evidence in these settings lacks consistency and standardized reporting of processes and outcomes. So future research should overcome these limitations and focus on hybrid effectiveness implementation studies that integrate the assessment of RT structure, team composition, incorporation of digital alert systems, and education as well. Thank you very much.
We thank you very much, Larissa, for your presentation. As you can see, we listened to the first talk about the importance and how the rapid response system changed the outcomes, and now we start listening about the huge gap that we have in low and middle income countries. We will have more time for this discussion later, but thank you for your presentation. So the next presentation is about the rapid response team and the critical care outreach team as needed efficient model of critical care delivery for Brazilian public and private healthcare systems. I invited Dr. Bruno Besen from University of São Paulo. Bruno is an intensive care physician of Camargo Cancer Center He is a researcher of Daryl Institute Research and Education and works in Hospital Sírio-Libanês in Brazil. And he's an advisor of the post-graduation program of Medical Science of Faculty of Medicine of University of São Paulo. Welcome, Bruno, and the time is yours for your presentation.
Paulo, for the introduction. So I'm very happy to be here, and especially with you and Daryl contributing for this important discussion for us. So in the next 10 minutes, I will try to focus on 5 main points, which is the current scenario of Brazilian intensive care units, how payment models lead to different incentives for whether we should or should not have mature rapid response team. The issue of healthcare spending also here in Brazil and how it is plummeting. How we use Brazilian ICUs right now based on the Brazilian registry, UTIs Brasileiras. And finally, why is the RRT and critical care outreach team an efficient and needed model for healthcare sustainability here, at least in our country? So first, we have good news. The number of ICU beds has been increasing. It was nearly stable until 2016, and then we started to have a steady increase. During the pandemic, we had a large increase in the number of ICU beds, and importantly, this increase was also observed in the public health system, in our SUS. So we have a large increase in the number of ICU beds. We still don't have the ideal number of ICU beds, but most importantly, we still have much to work because this distribution of ICU beds is different for public and private health system. So for the public health system, we have 52% of all ICUs in Brazil in the public health system, and they are used for they serve 75% of the population who don't have supplementary health care here in Brazil. And the other half of ICUs, they serve 1/4 of the population. So we have a very important disparity here in the provision of intensive care units, but at least we had an increase in the public health system number of ICUs. And additionally, we have regional disparities. I invite you to look at this report from the AMIB, Brazilian Intensive Care Medical Association, where this is presented for each state of Brazil so that you can take a look at how this is going right now. Okay, so the next point is that different payment models lead to different incentives. So why do we have so many intensive care units in the private healthcare system? Because the private healthcare system, the hospitals, they earn more if they have more ICUs. And because until recently, most of the revenue for hospitals was based on fee-for-service. So more ICU beds, the hospital has more revenue. You have, in theory, unlimited access to ICU beds, which is good for critical patients because there's an open ICU bed in theory. But this certainly leads to increased costs for payers, either public or private payers. And of course, we will see how having supplementary healthcare in Brazil is getting more and more expensive. There have been some attempts to move to a pay-for-performance model, but here in Brazil, this hasn't been so good. But the big problem here for pay-for-performance is that payments would be conditioned on a few performance characteristics. In theory, they are also good. So ICUs that don't have catheter-related infections will have a good standardized mortality rate, a good standardized resource utilization, low rates of VAP. But the problem is when you start a pay-for-performance model, the unintended consequence is that you may drive hospitals to avoid high acuity and high-risk care. And again, sending the most complex patients to the public health system, which already has fewer ICU beds than needed. And we now are moving to the idea of value-based healthcare, which is, in theory, also it's a nice solution, but it's hard to make this equation work. the equation is simple. We need to have in the numerator how good outcomes are. You can use any indicator for that. And in the denominator, how much it costs. So you want to maximize outcomes at the lowest possible cost. So in the end, if you want to use this solution ethically, our aim is to avoid unnecessary costs. Otherwise, what we mean by unnecessary, we don't want to compromise outcomes of patients because we are trying to avoid unnecessary costs. So we want the best outcomes at the smaller cost that is needed for that. And here's just a presentation of how much healthcare is contributing for expenditure of Brazilian families. Healthcare is much higher as part of the inflation in Brazil than the current IPCA, which is our current level of inflation in Brazil for all services. So healthcare is certainly something that we are increasingly spending for our families. So now going to the Brazilian registry. Here we can see how these incentives for opening more ICU beds, especially in the private system, has led to differences in how, at least here, patients who are mechanically ventilated and using vasoactive drugs. For example, for mechanical ventilation, we can see now in 2025, roughly 33% of patients in public hospitals are mechanically ventilated, while only 12% are mechanically ventilated in the private healthcare system. When we see vasoactive drugs, it's 30% in public healthcare system ICUs and roughly 15% in private ICUs. So what this tells us is that we are admitting many patients for our ICUs, especially in the private healthcare system, for monitoring. Many of these patients could potentially be managed in the wards, provided there was this system to ensure safety of their care. And if we see standardized mortality rates, we see we are decreasing, but still the public health system has a higher standardized mortality rate compared to the private healthcare system. And also resource utilization is higher in the public health system compared to the private healthcare system. Here we can see that we have two different realities. So in the public health system, maybe we need to improve outcomes for patients, while in the private healthcare system, we already have good outcomes and we can start to think how we can provide those good outcomes without increasing unnecessary costs. Just to put a little bit for discussion here, we can see that for mechanically ventilated patients, this difference is not so much, it's not so striking as it is for all patients admitted to the ICU. So there is something that is driving these big differences in standardized mortality rates, likely related to early admission of maybe not so critically ill patients. And so why is the model efficient for critical care delivery? First, we may reduce admissions only for monitoring. Many of these we know that they could be a patient, if there is a RRT in place, the patient can be admitted to the ward and he or she can be reviewed in the same day to see if everything is okay, instead of admitting to the ICU just for monitoring, for example. Also for those patients that are critically ill who need vasoactive drugs or who are on non-invasive ventilation, the RT or critical care outreach team may anticipate treatment plans that will be provided in the ICU and avoid further deterioration. For example, avoiding intubation if it's the case, if you can do that, of course. You don't need an additional structure for the RT except for maybe some equipment, but you need human resources, but human resources are much fewer than you need to open 10 ICU beds. So you need one physician, one nurse per shift. Ideally, you may or may not include respiratory therapists like Larissa showed us. instead of having 2 physicians during the day, 1 at the night, 2 nurses during the day and during the night, 5 nurse assistants, and all the human resources needed for opening an ICU. And importantly, we need to remember that the cost of an ICU, roughly 2/3 of it is for human resources. So the rapid response team and the critical care outreach team, it would be very efficient, both for the public health system and for the private healthcare system, but focusing on different aspects of it. So as key takeaway messages, in public hospitals, we may anticipate care of critically ill patients before ICU. We may avoid ICU admission, but importantly, we may avoid further deterioration. And when the patient is admitted to the ICU, he or she may be in a better condition than if the team doesn't exist. So efficiency here would come through better outcomes. And in the private healthcare system, deployment of the team may decrease admissions for monitoring without compromising outcomes. So efficiency here would come through reduced costs without compromising outcomes. So thank you very much. Of course, not all public hospitals are the same, neither all private hospitals are the same, and we need to adapt the structure of the team to each reality that we have. Thank you.
Thank you, Dr. Bruno, for this great presentation. Yes, it's showing the huge difference that we have in Brazil, like different models, different regions. It's quite important for us to be here together and to discuss all of these topics and different models. So for the next presentation, it will be about the 16-year experience from the Londrina. Londrina is a city in one of the states of Brazil, the state of Paraná, for you that are out from Brazil. So it's 16-year experience from Londrina with RRT CCOT led by the Intensivists. Dr. Gabriel Kreling will present this talk. Gabriel is an intensive care physician, specialist in internal medicine and intensive care medicine in the University of São Paulo, with postgraduate training in palliative care in Institute Pallium in Buenos Aires, and he is a PhD candidate in medical science from the São Paulo University. He is a care discussant at the Tele-ICU program of Hospital das Clínicas, University of São Paulo, and the Secretary of Health in São Paulo State, and he is our tutor. Botucatu Medical School is part of this program of Tele-ICU, and Gabriel is brilliantly leading this project with us. So Gabriel, the theater is yours.
Thank you, Professor Paula, for this kind introduction. Hello everyone. It's an honor to present to you the 16-year experience from Londrina with the rapid response team and the critical care outreach team led by Intensivists. This experience comes from the State University of Londrina, from their ICU team. And I would like to thank Professor Luciene and her team for their trust. Londrina is a city in the state of Paraná, as Professor Paula said, in southern Brazil. It's the largest inland city in the state, and Londrina serves as the main center for the northern region of Paraná here. With a population of about 2 million people, and the University Hospital was founded in 1971. Since then, it has been the main reference in healthcare for this population. The first RRT was created in 2009. At that time, the hospital had 315 beds and 20 ICU beds. The team was composed of one intensivist and one physical therapist. They worked 12 hours a day from 7 a.m. to 7 p.m. every day of the week. During the night, the coverage was provided by physicians and the emergency department staff. Nowadays, the current team in 2025 is still composed of an intensivist physician and a physical therapist, but the hospital reality is now very different. There are 58 adult ICU beds and 452 hospital beds. Since 2020, the team has been working 24 hours a day, every day of the week. And an important change came in 2015 that the patient triage moved from a chronological order to a prioritization system based on SCCM criteria. And this photo here shows part of the team. Here, Professor Luciani, the leader of all the ICU team. The rapid response team there can be activated in 4 main ways. First, code blue in case of cardiorespiratory arrest. Second, code yellow in case of significant clinical deterioration. Third, through ICU bed requests for critically ill patients. And fourth, through follow-up after ICU discharge. The team has clear response times: 2 minutes for code blue, 5 minutes for code yellow. They also perform daily evaluations of critically ill patients who are not yet admitted to the ICU, but are waiting for an ICU bed. This includes clinical assessment, review medical prescriptions, and providing guidance to the emergency department and to the wards team. Follow-up continues until the patient is transferred to the ICU or until the request is canceled due to clinical improvement or transferred to another institution. In addition, the RRT is notified of all ICU discharges. They follow these patients for up to 3 days after discharge. And now let's talk about the results. In this graph, we can see the number of patients evaluated by the team across the years. We can observe a significant increase in activations, especially after 2020, when the COVID-19 pandemic began, and the hospital and ICU expanded their beds. The main outcomes we observe here is transfer to the ICU. The second most frequent outcome is clinical improvement, here in light blue. Some patients, unfortunately, involve death. Transfers occur more often in 2020 and 2021 in the COVID-19 pandemic. And for a small group of patients, therapeutic limitations were applied with end-of-life care. Since the beginning of the team in 2009, there have been a total of 28,072 activations. The main outcome, as we mentioned, was ICU transfer, which occur in about 50% of cases. Around 27% of patients showed clinical improvement. 15% of them died. Therapeutic limitation with end-of-life care was applied in 30.6% of cases, and transfer to another institution occurred in only 2%. When we divide lead times according to SCCM priority criteria, we find an average lead time of 33 hours considering all years for priority 1. For priority 2 patients, the mean lead time was 57 hours. for priority 3, 37 hours, and for priority 4, 43 hours. Overall, the average lead time was 36 hours. It's important to note that priority 2 patients waited longer because many of them needed isolation beds. And since the number of isolation beds is limited, these patients had fewer available spots compared with priority 3 patients. It's also important to highlight the role of the RRT during the COVID-19 pandemic in the hospital. At the university hospital, the number of ICU beds varied greatly, as you can see here. In 2020, there were 68 ICU beds, and this number increased to 108 ICU beds in 2021, and then returned to 58 in 2023. At the peak of demand, there were 107 patients beyond this, the 108 available beds. The rapid response team in this time was the same, with 2 physicians on the weekends. In addition, there was a dedicated airway team led by anesthesiologists. Now let's talk a little about the scientific production as a result of having a RRT there. Over these years, many studies were published. Here I will highlight some of the main findings. The first one is a study that's widely cited in the literature. It showed that for every 1 hour delay in ICU admission, the risk of mortality increased by 1.5%. This is quite impressive. Here we have 2 studies. One evaluated the performance of the rapid response team. The other explored the opinion of the nursing staff about the rapid response team. And these studies show that in addition to the medical team, the nursing team was also engaged in scientific production. And this study described and evaluated the first 5 years of the team's working. This other one described a cohort of patients who waited more than 24 hours for an ICU bed. Since the RRT evaluates and follows ICU discharge patients for 3 days, this study aimed to evaluate the impact on readmissions rates after the service was implemented. It showed that after implementation, there was a sustained reduction in ICU readmissions. These 2 studies highlight the importance of RRT. One study showed the team as an extra set of eyes for patient safety and quality of care. The other, smaller study, looked at prioritization and its relationship with hospital outcomes. This one was a national survey. It shows that more than 90% of institutions reported an ICU occupancy rate above 90%, always or very frequently. And 85% of them had to refuse ICU admission because the unit was at full capacity. And quite impressively, 50% of institutions did not have triage protocol for ICU admissions. And finally, this study evaluated the impact of changing the triage process from chronological order to prioritization. The results showed an improvement in ICU performance and a reduction in hospital mortality. There was a mean difference of 1 day in length of stay in ICU and a hazard ratio of 0.87 for hospital mortality. So that's all, and I would like to thank you again for the opportunity to share this experience with you, and I also want to thank the entire team of the University Hospital at the State University of Londrina. Thank you very much.
We thank you very much, Dr. Gabriel, for this brilliant presentation, and congratulations to you and to Dr. Professor Luciene, who is here with us for this large experience, 16 years. It's like you have many things to share with all of us, the Brazilian, and with the other professionals and outside of the Brazil. So we will have time to discuss more about this. And now I would like to invite for the last presentation, Danilo Martins from São Paulo State University, where I am based as well. And Danilo will talk about the 7-year experience of the rapid response team. But here, the rapid response team is led by the emergency and the internal medicine team. So Danilo is a physician specialist in internal medicine in São Paulo State University, and he has just defended his PhD thesis in January 2025 in pathophysiology and clinical medicine in the area of POCUS ultrasound and heart failure. And he works in the rapid response team in the emergency department, and he also works in the clinical ICU, the ICU that I coordinate in the Botucatu Clinical Hospital at UNESP. So Danilo, you have 10 minutes for your presentation, and thank you.
All right, thank you, Dr. Paula. Good evening for Brazilians, good morning for Australians. Well, I'll try not to extend too much because we still have the parts of the questions for the participants. So I'll try to share a little about my experience of the rapid response team in my hostel that is has some quite difference from what Gabriel said, but you're going to see that we have lots of similarities, but we are quite younger than the rapid response team from Londrina. So I'll start to explain a little about our city, which is Botucatu. For those who don't know, Botucatu is a middle-sized city located in the state of São Paulo. We have about 130,000 inhabitants in the city. And we have one of the biggest universities in Brazil, which is São Paulo State University, which is different from University of São Paulo, despite the similar name, but it's still a great university. And this university has a lot of units in the state, and one of these units is located in Botucatu, which is the Botucatu Medical School. So Botucatu Medical School has a tertiary teaching hospital that have about 400 ward beds and 50 ICU beds. And it have about 25,000 hospitalizations in a year, and attends a region of about 2 million people. So not only the population of Botucatu, but also the population of the cities around Botucatu. So it's a very big hospital. It is considered one of the biggest public hospitals in the country. And we are a referral center for emergency and intensive care, and we have some specialized services like cardiac and renal transplant center. And recently we were allowed to make a service of a lung transplantation center. So we are still growing up, and that's because we have a long history of existence. So our hospital have more than 60 years of history. But despite of this age, our rapid response team started just 7 years ago. So here you can see some photos of the first team that we had in our first year, and we began a very small team, and now we have a bigger team. But we had some difficulties on the beginning of our creation. So we started on 2018. And our team was created by the internal medicine department. And why the internal medicine department and not the intensive care or the emergency? It is because the internal medicine department in our hospital is have a bigger team, more than the intensive care. So for to have an idea, we have about 30 residents in a year in the internal medicine and about 2 in intensive care medicine. So most of the patients with that needs critical care, they are attended by the internal medicine department. So and at that time, when we started in 2018, we still had an emergency training program. So the emergency was recognized as a specialty in Brazil very recently, 10 years ago, about 2015. But our training program started in 2021. So the rapid response team created by the internal medicine influenced the emergency training program in our hospital. So nowadays we have most of the consultants compound the team specializing in internal medicine, but also have a growing up number of people with emergency training, and we have a few of the consultants with intensive care training. So on the first year that we started only during business hours, so 12 hours a day from Monday to Friday. And it was only after 1 year of our work that our hospital recognized our service, and we could bring more people to work with us together. And so we started to work 24 hours a day and 7 days a week, very similar to the experience from Londrina. And our team is now composed by 1 consultant, 1 nurse, 1 resident, and 1 medical student. And during nighttime and weekends, only 1 consultant and 1 or 2 residents, depending on the day. So unfortunately, we have only 1 nurse on the business hours, and we miss a lot this professional because it makes a lot of difference during the calls. So this nurse is working with us since 2018, and unfortunately, he is going to retire in the next 2 years. So this is one point that we have to improve in our hospital. Regarding our activation, so our rapid response teams are activated by phone calls. So we don't have loudspeakers or alarms. We used to attend the phone when the afferent link call us, and then we have to ask for 3 questions. So the first one, it's protocol. We ask, what is the code? And then we ask, where is the code? And finally, which criteria if it is an yellow code. So we have 2 types of activations. We have the yellow code and then the red code. The yellow code is the traditional medical emergency team call. So we have objective criteria, a list of these ones, and we use this code to make an activation for patients that is having some deteriorating signs. And the red code is the same thing as the blue code, but why we change the color? We thought at that time that the color red could give more sense of urgency or emergency, and it would be easier to explain to our healthcare professionals. So we changed the color, but it's the same things. It's the code that is used for cardiac arrest suspected or confirmed. So when we are activated, we move to the local. We take about 5 to 10 minutes in a maximum, but normally we take even less than 5 minutes depending on the local of the activation. And we make the attendance with the assistant team, and then we come back and register on the medical electronic record. And we still have other functions on the hospital, and one important function is related to the administrative link. So our rapid response team is responsible to the regulation of patients that needs to go from other places, other hospitals outside Botucatu for our hospital. So every time that a patient needs to be transferred to our hospital, we have to analyze this patient and check if this patient have criteria to go here or not. So we work together with the center of the internal regulation from hospital to make this function. And I would like to highlight an important role that we have in an educational role in the university, that most of our consultants are also professor of the university. And one point that most residents feedback us with a positive feedback is this educational role, because most of these residents sometimes call us not because they are having doubt of how to conduct this patient, but because they want to learn more on how to assist the deteriorating patients. And I think this is one of the most important features that makes our rep response team with a good positive feedback from the assistance teams from all over Oslo. So it's a very quite summarize of how we work. We have some researches mainly about cardiac arrest. So here, as you can see, some of our publications with our data. Unfortunately, it happens because it is one of the major points that we have to improve in our hospital. We have about 400 cardiac arrests in a period of 3 years of these studies. It's a higher number. I don't know the number for each 1,000 admissions. It's a data that we have to study. But at least we could study more this condition that we don't have so many data in the literature, especially regarding in-hospital cardiac arrest. And we still are improving some other areas. For example, recently we conducted a survey very similar to what Professor Daryl did in Australia, to understand what are the barriers of activation for our rapid response team. We still don't have this study published. We are working on it, but we found some similar findings comparing to other countries, and some interesting things that may influence the rapid response team in a latent country. Also, we have to understand what is the role of yellow code since our rapid response team implementation. Since our creation, we still don't have worked at this data. We are working on it, but it is important to have objective data of how was our mortality, how it impact the ICU admission and things like this. And finally, other important thing that we are working on is the understanding the delays of activation. So we already know that delays of activation for the rapid response team is associated with worse prognosis, but we still don't know how frequently is it in our hospital and how it impacts in our mortality and in our ICU and our assistance in our patients. So finally, I think this is a great opportunity to make partnerships with our rapid response team. We believe that these partnerships are very important, not only for research, but to improve ourselves. So that's why we are doing this webinar. And I think we have so much to improve each other and to share so much experience with each other with our experience in rapid response teams and at all. So I will not extend so much. So I'd like to thank you, the participation, and I will pass to Dr. Paulo. So
thank you very much, Danilo, for introducing our rapid response team for the world. And yeah, I'm very, very glad of listening all of your presentations, and we need to discuss more about the benefits and how to implementing the rapid response systems in different realities and with different teams. And we have, at this moment, we have 2 questions from the YouTube. And I will start with these questions. I think we can share the opinions. I want to let you know that we, in addition to the speakers, we have also Professor Lucieni from University of Londrina, State University of Londrina, and Dr. Márcio from the Porto Alegre Medical Hospital. So they also run rapid response systems. So they will join us for this discussion. I would like to make these questions for you. So Luis Otávio Ferraz asked, Professor, it's clear that math importance, but how can we implement it with efficiency? I think, Daryl, maybe you could try to start this with this, responding this question.
Thank you. I think it's a very good question. I think you could do a limited introduction. You could introduce it into the wards where you have the most adverse events or the most cardiac arrests, so that you have the biggest return on your investment. So I think probably the best evidence or the most evidence is in surgical patients. A lot of our surgical patients have medical problems, and it's often surgical doctors that are mostly looking after them. And I think that's probably where the rapid response team has the most to add. And I guess each hospital might have a different risk profile or different patient profiles, and you could see where your most of your cardiac arrests are. So if you wanted to be efficient, you could have a limited and staged introduction in the areas that have the most risk or the highest risk surgical patients, I think.
Perfect. Anyone else would like to?
I think that it's important to know the reality of the hospital. What kind of patients do you have, your case mix, and know the reality about the yellow code and blue code, and how to be objective, as Professor Daryl.
I think starting small and mapping the areas, the most, like Daryl said, like surgical patients, surgical wards. And in our case in Botucatu, when we started, it's not easy to start or to convince the administrative board sometimes. Sometimes they don't know very well what we are trying to deliver with that, but start small, one period, not 24 hours, for instance, and actually the surgeons helped us to have the team for 24 hours because they said we can't live anymore without the rapid response team. So please, we need to have this team over the night, because we are all of the day doing the surgery in the theater, and this really helped us to support our patients. So I think small mapping what is your biggest problem, and also collecting the data. When you show the data, then you can say, oh, it's worth having the team. All right, we have other questions. Ana Clara Almeida, she asked that, she said that rapid response teams, they cost more money to the healthcare service than the ICU without borders. What would be the model of assistance that could really improve the outcomes of the patients? Do you have any data about the costs? Do you think it costs more than having the ICU without borders, or can we say that the ICU without borders is like a kind of rapid response system, I think?
Yeah, I think the idea of the ICU without borders is more similar to the critical care outreach team. That is a little bit of different than the definition of rapid response teams. So critical care outreach teams, they exist in Australia as well and in England mainly, and they are usually led by a nurse, not a physician. But in Brazil and many other low-income countries, what we saw when reviewing the data is that most teams are led by a doctor, and maybe this is related to lower nurse to patient rates that we have, worse remuneration. So usually people have to work with what is available. So in some places it will be like the intensivist, in other places it will be like the internal medicine. And if it's somebody with the qualification, it is good. I do believe, and Daryl can maybe share his experience with that with time, the role of the rapid response team can expand more and not only manage acute deterioration, but help to define goals of care discussions and prioritize ICU admission. And this is like maybe the feature of a more mature rapid response system or critical care treat system. But the first step is to at least have people that are qualified to manage these patients that deteriorate in the wards. And this is not only it involves all the rapid response system, because the person who is at the bedside has to have some knowledge to activate the system as well. Otherwise, the system will not have the efficiency that it should have.
I would agree, Larissa. I think that it's really difficult to do cost analyses on rapid response systems because you're not working in a static environment. The healthcare system's constantly changing. And so they're usually before and after studies, unfortunately. But I think that the outreach team or the rapid response team has the potential to see really 20, sometimes 30 patients in a 24-hour period. You cannot possibly admit all of those patients to the intensive care unit. And so I think the value add is to triage the patients to get the ones that are most appropriate to go to ICU, and then to monitor the ones that are stable enough to stay on the ward to see if they're continuing to improve, or maybe they need admission to the ICU if they deteriorate. But as has been alluded to, one of the things that they can do is have goals of care discussion in association with the family and the treating team, the usual team, and potentially prevent non-beneficial admissions to the intensive care. And that is not just cost saving, but it also potentially reduces moral distress to the staff that are in the ICU, and maybe reduces attrition rates of the nurses in the intensive care unit as well. That's one of the reasons intensive care nurses in Australia leave ICUs, because of the need that they have to provide burdensome and non-beneficial care to patients.
Wonderful, thank you. And we have another question. Noah Simons asked to Danilo, Dr. Danilo, congratulations for your rapid response team. And what's your expectation for your team with recent emergency medicine growing in your country?
Well, thank you, Noah. Sometimes I have an impression that we are on the beginning of the process that Australia was 20 years ago. And when we talk about the emergency team, we are having a very good experience. So I believe that in this year, 20 to 30% of our team is compounded by emergencies, and our expectation is that we are going to grow up this kind of specialists in our team. Probably because our rep response team influenced the creation of this residence program. But to be honest, I don't know if it is this same reality in Brazil, because we are so big country and so different. We have so many specific issues in each hospital, in each region, that I believe that not all hospitals have some emergencies working on the rapid response team. So we may have a majority of the hospitals with rapid response teams led by intensivists. I have already heard about one hospital from one resident that was led by cardiologists. So it's very interesting because we may not have a singular pattern. We may have lots of different issues compounded by hospitals. So I have a good expectation for the emergency, but it is still something that is on the beginning. We have to understand better how it works in our country. I don't know if my colleagues from Brazil want to share their experiences related to this, but I think that's the answer.
Yeah, and I also believe that I think this is why we are one of the reasons that we are here, because we can see that the rapid response system sometimes is led by emergencies, sometimes led by cardiologists, anesthesiologists, and from intensive care team. As Larissa said, I think the training, be prepared for working in these wards with patients at risk of clinical deteriorating. I think maybe we need to have a Brazilian checklist of the minimum framework for this. And I think the most important is that sometimes in our service, for instance, the internal medicine team is very we have a large team, and we are a very academic team. So we run these patients, the perioperative care and the clinical perioperative care, and sometimes the more emergency care. So it depends on the hospital, the reality of the region. But yeah, I think the possibilities are very, very large possibilities. Marcio, do you want to?
Yeah. Does anyone have experience with the rapid response team managing ICU beds? Because in our hospital, the rapid response team is responsible for ICU bed managing. Every ICU bed request from the emergency department, the operating room, and of course from wards, goes through the rapid response team. We previously had a negative experience at another hospital where it was very difficult to secure an ICU bed for an unstable ward patient. So that's why we implemented our system with this feature. Does anyone have experience like this?
Yes, we have this experience here in Londrina. We created our rapid response team to outreach our patient, our code blue and our code yellow, but we also have another action for our rapid response team, for our team, that is to take care of our ICU patients outside the ICU. So our critical care team take care of these patients till they get to the ICU. I think that the model of the rapid response team depends on of your number of ICU beds. If you have a number of ICU beds that you can have immediate admission to your patients, this is you just need a rapid response team. But if you have not enough ICU beds, you have to take care of them outside of the ICU. So you have to transform your rapid response team, your initial rapid response team into outreach ICU team. We have this line, we have this prioritization, this organization of the ICU line, and we do prioritization like the SCCM tells, and we have a doctor, a constant 24 hours per 7 to take care of this line, so we can establish who patient is going to the ICU bed that is opened at that time. Today I'm in duty, so in some time I'm going to lead this team, and we do this all over the year.
Brilliant. And yes, as you can see, the rapid response systems are also involved in some beds regulations because they are in the middle of the emergency wards and ICU. So I think it can be something that the rapid response system can help to manage in the hospital. Dr. Helio Pena has just joined us at this moment. Dr. Helio is an emergencist and intensive care physician, and he is the supervisor of the emergency residence program of the Clinical Hospital of the University of São Paulo, and he also is a president of the Latin America Emergency Medicine Federation. So for the last question, I will maybe Dr. Helio could help us to respond to the last question, and also I will come back to the question that Dr. Noah made to Danilo. So I will make the two questions. Maybe Dr. Helio could help us to also to respond this. So we have here one question is that is there a model that matches internal medicine, emergency, and intensive care medicine staff to attend a potentially unstable patient at ward? This is one question. And I will come back to the other question was that Danilo presented our rapid response system led by the emergencies. And the question is, what is the expectation for the emergencies working at the rapid response system, considering that the specialty of the emergency medicine in Brazil is quite new? So is there a place for the emergencies to work in the rapid response systems? So I would like, if you would like to make some comment about that. So.
Okay. So, hello everybody. Sorry for delay. I was on call, and the traffic in São Paulo is terrible. So let me think about these questions. Let me start by the second question. I know that emergency medicine is a very new specialty in Brazil, but I believe definitely it's necessary to the emergency guys start working the rapid response teams. I know that the big problem maybe now in Brazil is the number of the emergency doctors on call during the turns, the time to how can I say, to get one of these guys to try to organize or try to work in the rapid response team around the hospital. Most of the hospitals in Brazil start working in the rapid response teams using intensive care, for example, the private hospitals. And some public hospitals start to working the guys from the emergency medicine or some guys from the internal medicine. I don't know if my opinion is a good opinion in this scenario, but I believe maybe the best guys to work in these scenarios definitely is the guys from the emergency medicine and the guys from the intensive care, because I think it's a necessary a kind of good communication to make this transport and some support for these patients that involve the ICU and emergency care. It's more easy when these two specialists work together. And I believe that sometimes using the internal medicine, sometimes there are some public hospitals I know, I work in one of them, that they decide to use the residents for internal medicine or staffs for internal medicine to work as a rapid response team in the hospital during the times, for example, during the night or during the afternoon. And I believe my experience is not a good experience in this scenario, because sometimes these guys not they don't know what the point of the is necessary to get this patient go to ICU, and sometimes try to get this guy to back to emergency room again, or sometimes try to make some actions on the ward, for example, ventilation or some invasive conducts, and it's more difficult to get this guy to transport these guys to ICU. So I don't know if it's my opinion is definitely is not, maybe it's not so nice about this, but I think the best scenario is to work together, guys from ICU and the guys from the emergency medicine, building this team.
Yeah, what we were talking about, I think we have space for everybody that really is trained for this task. In Botucatu Medical School, we run everything by the emergency medicine team. So I am the coordinator of the ICU, of the clinical ICU, and I am from the emergency medicine team. And also the emergency, we run the emergency room. So I think it depends, because in Brazil, sometimes when we say emergency, internal medicine, sometimes we think that there are some general practitioner that without training, but it's different from the medicine team, like the hospitalists, the internists. So I think there is a space for everybody that is really trained for that job, and we need to state like some basic, some framework to doing that. But yeah, Daryl, please.
Thank you, Paul. I agree with the comments you've just made. I think some of the issues might just relate to the number of people that are available in each specialty. So in Australia, we wouldn't have enough emergency physicians to run the rapid response team because there's not enough of them. In Australia, we have a combination of, we have rapid response team responses in the emergency department, so the ED will go to their own calls. But on the ward, it's a combination of intensive care and internal medicine. And I agree with Professor Paulo that they're not the physicians that only work as outpatients. They mostly work in the hospitals. And the patients that stay on the ward and don't go to intensive care, they tend to be followed up initially by internal medicine, and intensive care can come and see. But I agree, the most important thing is communication between the various teams, irrespective of who's in the team. And I agree with you that they need specialist training, that there needs to be a framework for training. Not everybody can do it.
And we have another question here. It's about yellow coat signals, patients at risk of deterioration. In addition to assessment and reassessment, how to conduct a safe screening to keep a priority 2 patient in the ward or transfer them to the ICU.
I don't know, it's just for me or for everybody?
For everybody. If you want to start, please go ahead.
Okay, go ahead. But I think it's, as Professor Daryl and as Paula talk, I think it's absolutely necessary to be training to work in a rapid response team. And much more, sometimes much more just in using score, sometimes it's necessary, how can I say, a kind of feeling. So one of the points that I really like in this course is that point that say the patient is not so good, it's not same so good for me. And sometimes this is the point to get a yellow code or to call a yellow code. And it's difficult to use the priorities here, I know, because as I told you, when I work in Brazil in a private hospital, most of the big private hospitals in Brazil have enough resources to put this patient in ICU or in cement or intermediate unit. But when we stay in a public hospital, sometimes just have one or to have one place in the ICU in normal places, and sometimes go to again to the emergency room, and this is a big problem because the emergency room most of the time is they have 1,000 of patients, and one more patient get to the ward to emergency room, always the problem. But I know the most important, maybe the most important thing, that's a thing that I decide when I stay in this situation, and think about the prognosis and about the history of these 2 patients. And it's important to try to know a little bit about these patients and know about the how is the prognosis, how can you offer based in the signal that they presents in this moment, based in that signal, how is the best choice to place the patient, to put this patient in the right place, the ward or the go to the ICU.
And actually, I think that if necessary, if we don't have, if you don't have a bed for this patient, and it's really necessary to keep the patient priority 2 in the ward, I think protocols, discussing the protocols and to have the help of the rapid response systems or the outreach ICU team, I think it would be the best thing to do to keep your patients out of the ICU with safety. And I think we have a long way to cross over here in Brazil, maybe trying to discuss more about these protocols and trying to improve the care of these patients that are in the ward and at risk of deterioration. All right, so I think we had very good questions. I loved these conversations. The presentation were brilliant. And for me, I learned lots of different things with you. I would like to open the microphone for you to have your final considerations. Maybe Professor Daryl, if you could, if you want to start, or
Thank you. Yeah, I think what it's highlighted to me is that there's no one perfect model, and that sometimes you need to adapt the model for what you have in your resources and what your hospital treats and the type of patients you have. So that's the most important thing. But we do need structures and processes.
Gabriel?
So I think that we have a very good field here in Brazil because as Bruno said, we have a big opportunity to use this tool. I think it's a very important tool. The RRT is an important, and critical care outreach teams are important tools to deal with our scenario. So thank you for this first webinar and to start this discussion. It's very important, and I think that we can save lives with this improving care of this patient outside the ICU, and I think that we have a lot of work to do. So thank you.
Thank you. Larissa, please.
I agree with my colleagues. I think this is a very important topic, and we have very good experiences in Brazil, like my colleagues shared. But Brazil is a big country. We do not have a complete landscape of how in other places things work. So we have lots of challenges ahead, but it's really nice that we can discuss more and start going through this path to improve outcomes.
Danilo, please.
Well, I have no additional comments. I agree with all my colleagues. So thank you for the webinar. Thank you, everybody. I would just invite the participants, if someone has some doubt or someone are interested in discuss with us rapid response systems. So send an email to us. We shared our contacts. So I think it's a good opportunity for us to create a group and to improve together. And again, thank you everybody for the webinar. It was very good.
Dr. Hélio, please.
So thank you so much. I think the most important point is definitely this kind of system, rapid response systems, saves life, as Gabriel says. And this is a not so old concept in Brazil. I have been working in ICU emergency care at least 30 years, and you start to talking about the TRR in the last 5 years. There are some pioneers in this. Botucatu is a pioneer team. There are some pioneer teams in São Paulo, but you just definitely you should get start this kind of program around the country, and it's necessary to present this kind of concepts for everybody. So this kind of webinar is very important for the Brazilian medicine, not only for ICU, emergency care, internal medicine, but all the doctors. So thank you so much for this opportunity.
We thank you. And yeah, actually, this was our idea, because sometimes we don't know what is happening across Brazil, so we had the opportunity to meet these people that is working with rapid response system. So the top of my head, maybe Professor Luciene, who is besides you in my screen from State University of Londrina, you have the most experienced team because it's 16 years of rapid response system. And our team is about 7 years. And I think that Marcio, Dr. Marcio, that is also here, and he can say his experience. And if you are listening to us from Brazil and you have some experience or you want to learn more, as Danilo said, please contact us. So I will open the microphone for you, Professor Luciene, please.
Thank you very much, Paula. I'd like to thank you the opportunity to talk about this. I never thought I was the only one in Brazil in my place, but I was alone in my place. And I would like to thank the opportunity to share with all of you our experience. Once a campaign said that soon is not a time, and some is not a number, and I truly believe this, and we need to make more to all these people that are in jeopardized their clinical status, and to bring them as soon as possible to the ICU or take care of them out of the ICU with an ICU without borders wherever they are. Thank you very much for you all.
Thank you. Dr. Marcio, please.
Thank you. Yeah, we have had the rapid response team in our hospital for 11 years, so it's a good experience too. And I just want to congratulate you on this initiative. I think it's really, really important for developing a rapid response team in Brazil, especially having Daryl's experience with us. So thank you so much.
Okay, thank you for all of you, for everyone who listened to us this night. This webinar will be recorded, and my apologies for the beginning of the transmission, that we have some technical problems, but I think we could fix it. And I'm really, really glad of starting this conversation. I wish you all a very good night, and that you think about how we can make it better for our patients in Brazil with different models, thinking about training, thinking about structure framework, and I think that's it. Thank you very much, and have a good night, everyone. And I also want to thank you, Guilherme and Gustavo, the team that supported us this night with the transmission and with the question. Thank you very much. See you. Bye.
Thank you. Bye-bye.